Dear students, today I feel like talking about the sequence of orthopedic patients' examination and examination methods. First of all, to achieve predictable success in this technically exacting and demanding field, there must be meticulous attention to every detail, from the initial patient interview and diagnosis through the active treatment phases and to a planned schedule of follow-up care. Otherwise, the results likely to be unsatisfactory and frustrating for both dentist and patient, resulting in disappointment and loss of confidence in each other. Problems encountered during or after treatment can often be traced to errors and omissions during history taking and initial examination. An experienced clinician may plunge into the treatment phase before collecting sufficient diagnostic information that helps predict likely pitfalls. Making the correct diagnosis is a prerequisite for formulating an appropriate treatment plan. This requires that all pertinent information be obtained. A complete history includes a comprehensive assessment of the patient's general and dental health, individual needs, preferences, and personal circumstances. So, about history. A patient's history should include all pertinent information concerning the reasons for seeking treatment, along with any personal information, including relevant previous medical and dental experiences. The chief complaint should be recorded, preferably in the patient's own words. A screening questionnaire is useful for history taken. The example of a screening questionnaire you could see on the picture. It should be reviewed in the patient's presence to correct any mistakes and to clarify inconclusive entries. If the patient is mentally impaired or a minor, the guardian or responsible parent must be present. Chief complaint. The accuracy and significance of the patient's primary reason or reasons for seeking treatment should be analyzed first. These may be just the obvious features, and careful examination often reveals problems and disease of which the patient is unaware. Nevertheless, the patient perceives the chief complaint as the major problem. Therefore, when a comprehensive treatment plan is proposed, special attention must be given to how the chief complaint can be resolved. The unexperienced clinician trying to prescribe an ideal treatment plan can lose sight of the patient's wishes. The patient may then become frustrated because the dentist apparently does not understand or does not want to understand the patient's point of view. Chief complaints usually belong to one of the following four categories. First of them is the comfort, can be pain, sensitivity, or swelling. The second is the function, for example, difficulty in mastication or speech. The third is social, bad taste or odor, and appearance, fractured or unattractive teeth or restorations, or discoloration. Comfort. If pain is present, its location, character, severity, and frequency should be noted, as well as the first time it occurred, what factors precipitate, for example, hot, cold, or sweet things, and any changes in its character. It is often helpful to have the patient point at the area while the dentist pays close attention. If swelling is present, the location, size, consistency, and color are noted, as well as how long it has been felt and whether it is increasing or decreasing. Function. Difficulties in chewing may result from a local problem such as a fractured cusp or missing teeth. It may also indicate a more generalized malocclusion or dysfunction. Social aspects. A bad taste or smell often indicates compromised oral hygiene and periodontal disease. Often social pressures prompt the patient to seek care. Compromised appearance is a strong motivating factor for patients to seek advice as to whether improvement is possible. Such patients may have missing or crowded teeth, or a tooth or restoration may be fractured. Their teeth might be unattractively shaped, malpositioned, or discolored, or there may be a developmental defect. Poor appearance is a common reason for seeking restorative dental treatment, as you can see on this photo. Personal details. The patient's name, address, phone number, sex, occupation, work schedule, and marital and financial status are noted. Much can be learned in a 5-minute casual conversation during the initial visit. In addition to establishing rapport and developing a basis for the patient to trust the dentist, small and seemingly unimportant personal details often have considerable influence in establishing a correct diagnosis, prognosis, and treatment plan. Medical history. An accurate and current general medical history should include any medication the patient is taking, as well as all relevant medical conditions. If necessary, the patient's physician or physicians can be contacted for classification. The following classification may be helpful. First, conditions affecting the treatment methods. Any disorders that necessitate the use of antibiotic premedication, any use of steroids or anticoagulants, and any previous allergic responses to medication or dental materials. Once these are identified, treatment usually can be modified as part of the comprehensive treatment plan. Although some factors may severely limit available options. Conditions affecting the treatment plan, for example, previous radiation therapy, hemorrhagic disorders, extremes of age, and terminal illness, this can be expected to modify the patient's response to dental treatment and may affect the prognosis. For instance, patients who have previously received radiation treatment in the area of a planned extraction require special measures to prevent serious complications. The third, systemic conditions with oral manifestations. Periodontitis may be modified by diabetes, menopause, pregnancy, or the use of anticonvulsant drugs. In cases of gastroesophageal reflux disease, bulimia, or anorexia nervosa, teeth may be irradiated by regurgitated stomach acid. Certain drugs may generate side effects that mimic temporomandibular disorders or reduce salivary flow. Possible risk factors to the dentist and auxiliary personnel: patients who are suspected or confirmed carriers of hepatitis B, acquired immunodeficiency syndrome, or syphilis. Dental offices practice universal precautions to ensure appropriate infection control. This means that full infection control is practiced for every patient. No additional measures are needed when dentists treat known disease carriers. On the left side, you could see the extensive damage caused by self-induced acid regurgitation, and below you could see the severe gingival hyperplasia associated with anticonvulsant drug use. Dental history. Clinicians should be cautious when commenting before a thorough examination is completed. With adequate experience, a clinician can often assess preliminary treatment needs during the initial appointment. Fairly assessing the quality of a previous rendered treatment can be difficult because the circumstances under which the treatment was rendered are seldom known. When such an assessment is requested for legal proceedings, the patient should be referred to a specialist familiar with the usual and customary standard of care. Periodontal history. The patient's oral hygiene is assessed and current plaque control measures are discussed, as are previously received oral hygiene instructions. The frequency of any previous debridement should be recorded, and the dates and nature of any previous periodontal surgery should be noted. Restorative history. The patient's restorative history may include only simple composite resin or dental amalgam fillings, or it may involve crowns and extensive fixed dental prostheses. The age of existing restorations can help establish the prognosis and probable longevity of any future fixed prosthesis. Endodontic history. Patients often forget which teeth have been endodontally treated. This can be readily identified with radiographs. The findings should be reviewed periodically so that periapical health can be monitored and any required lesions promptly detected. Defective endodontitis has led to recurrence of a periapical lesion, as you can see on this picture. And this patient required retreatment. Oral surgical history. Information about missing teeth and any complications that may have occurred during tooth removal is obtained. Special evaluation and data collection procedures are necessary for patients who require prosthodontics care after orthodontic surgery. Before any treatment is undertaken, the prosthodontic component of the proposed treatment should be fully coordinated with the surgical component. Radiographic history. Previous radiographs may prove helpful in judging the progress of dental disease. They should be obtained if possible, because it is generally better to avoid exposing the patient to unnecessary ionizing radiation. Dental practices usually forward radiographs or acceptable duplicates promptly on request. In most instances, however, a current diagnostic radiograph series is essential and should be obtained as part of the examination. Temporomandibular joint dysfunction history. A history of pain or clicking on the TMGs or neuromuscular symptoms such as tenderness to palpation may be caused by TMG dysfunction, which should normally be treated and resolved before fixed prosthodontic treatment begins. A screening questionnaire efficiently identifies these problems. The patient should be questioned regarding any previous treatment for joint dysfunction, for example, occlusal devices, medications, with feedback of physical therapy exercises. Facial proportions and symmetry in the frontal plane you could see on this picture. An ideally proportional face can be divided into central, medial, and lateral equal fifths. The separation of the eyes and the width of the eyes, which should be equal, determine the central and medial fifths. The nose and chin should be centered with the central fifth, with the width of the nose and the same or slightly wider than the central fifth. The interpupillary distance, its dashed line, should equal the width of the mouth. Composite photographs are the best way to illustrate normal facial asymmetry. For this boy, whose mild asymmetry rarely would be noticed and is not a problem, the true photograph is in the center. On the patient's right is a composite of the two right sides. On the left picture, it is a composite of the two left sides. This dramatically illustrates the difference in the two sides of a normal face, in which mild asymmetry is the rule rather than the exception. Usually, the right side of the face is a little larger than the left, rather than the reverse as in this individual. In evaluating facial proportional relationships while looking at digital images on the computer screen, it can be helpful to put a box around the structures to be related. As in A photo, where the lip commissure height is being related to the central philtrum height, or as in B picture, where the width of the nose is being related to the interocular width. For this girl, both relationships are normal. Boxes like this can be added to the facial image during the clinical examination and become part of the record. Vertical facial proportions in the frontal and lateral views are the best evaluated in the context of the facial thirds, which the Renaissance artists noted were equal in height in well-proportioned faces. In modern Caucasians, the lower facial third often is slightly longer than the central third. The lower third also includes thirds. The mouth should be 1/3 of the way between the base of the nose and the chin. The usual cause of excessive display of maxillary gingiva is a long face due to excessive downward growth of the maxilla, which moves the maxilla down below the upper lip and results in a disproportionately long lower third of the face. This should not be confused with display of gingiva in childhood, because the gingival recession that accompanies eruption is incomplete, or with gingival display due to a combination of incomplete eruption and a short upper lip. Note that for the patients in A and C, the lower third of the face is long, whereas for the patient in B, the lower third is about the same length as the middle third. Accentuated profile convexity or concavity results from a disproportion in the size of the jaws, but does not by itself indicate which jaw is at fault. A convex facial profile indicates a class II jaw relationship, which can result from a maxilla that projects too far forward on a mandible too far back. A straight or slightly convex profile is normal and usually reflects a normal jaw relationship. A concave profile indicates a class III jaw relationship, which can result from a maxilla that is too far back or a mandible that protrudes forward. There are 8 components of a balanced smile. They are the lip line, smile arch, upper lip curvature, lateral negative space, smile asymmetry, occlusal frontal plane, dental components, and gingival components. First, the lip line. The lip line is the amount of vertical tooth exposure in smiling. In other words, the height of the upper lip relative to the maxillary central incisors. As a general guideline, the lip line is optimal when the upper lip reaches the gingival margin, displaying the total cervico-incisal length of the maxillary central incisors along with the interproximal gingiva. A high lip line exposes 2 of the clinical crowns plus contiguous band of gingival tissue, whereas a low lip line displays less than 75% of the maxillary anterior teeth. Because female lip lines are on average 1.5 millimeters higher than male lip lines, from 1 to 2 millimeters of gingival display at maximum smile could be considered normal for females. Dental professionals have been conditioned to see a gummy smile as undesirable, but some gingival display is certainly acceptable and is even considered a sign of youthful appearance. The starting point of a smile is the lip at rest, with an average maxillary incisor display of 1.91 millimeters in men and nearly twice that amount, 3.40 millimeters in women. With aging, there is a gradual decrease in exposure of the maxillary incisors at rest and to much lesser degree in smiling. A steady decline in maxillary tooth exposure at rest is accompanied by an increase in mandibular incisor display. It is important to differentiate between the posed smile and the spontaneous smile. A posed smile is the voluntary expression made when introduced to someone or when taking a passport photograph or orthodontic records. A posed smile is repeatable. Studies have found little difference among numerous consecutive photographs of posed smile by the same individuals. A spontaneous smile, by contrast, is involuntary, natural, and driven by emotions. With all the muscles of facial expression involved, a spontaneous smile always has more lip elevation than a posed smile. Most studies refer to the posed smile because it is reproducible and can therefore be used as a reference position. Upper lip length. The average lip length at rest, as measured from subnasal to the most inferior portion of the upper lip at the midline, is about 23 millimeters in males and 20 millimeters in females. What is significant, however, is the relationship of the upper lip to the maxillary incisors and the commissures of the mouth. Lip length should be roughly equal to the commissure height, which is the vertical distance between the commissure and a horizontal line from subnasal. A short lip length relative to commissure height results in an anesthetic reverse resting upper lip line. It is not easy to alter commissure height, but lip lengthening is possible with lip surgery, either as a single procedure or in combination with a left forward one osteotomy. On the photograph A, you can see the lip length compared to commissure height, normal lip length at rest. On the picture B, there is a reverse resting lip line. Upper lip length. Continue. In the old sense, a short upper lip relative to commissure height could be considered normal because of the lip lengthening that continues even after vertical skeletal growth is complete. It is interesting to note that a short upper lip is not always associated with a high lip line. On the contrary, the upper lip was found to be longer in a gingival display group than in a non-displaying sample. Lip elevation. In smiling, the upper lip is elevated by about 80% of its original length, displaying 10 millimeters of the maxillary incisors. Women have 3.5% more lip elevation than men. Actually, there is considerable individual variability in upper lip elevation from rest position to the full smile, ranging from 2 to 12 millimeters with an average of 7 or 8 millimeters. If a gingival smile is caused by a hypermobile lip, it would be a mistake to correct it with aggressive incisor intrusion or maxillary impaction surgery, because that would result in little or no incisor display at rest and thus make the patient look older. Excessive lip elevation should therefore be recognized as a limiting factor. Likewise, if a low lip line is due to a hypermobile lip, extensive incisor extrusion would result in an overbite with excessive incisor display at rest. Here you could see the patient with limited lip elevation from rest position to full smile. Absence of gingival display despite high lip line at rest is due to hypomobile lip. Here you can see a patient with excessive lip elevation from rest position to full smile. On the picture B and C, after orthodontics and maxillary impaction surgery, persistence of some gingival display after treatment is due to hypermobile lip and short clinical crowns. Mere surgical impaction would have resulted in no incisor display at rest. Vertical maxillary height. The importance of the vertical position of the maxilla into display has been demonstrated in both prosthetic dentistry and orthodontic surgery. When upper lip length and mobility are normal, a gingival smile with excessive incisor display at rest can be attributed to vertical maxillary excess. This kind of skeletal gingival smile is generally associated with excessive lower facial height. Conversely, a low lip line with no incisor display at rest is skeletal, when associated with inadequate lower facial height due to a vertically deficient maxilla. In picture, you can see a patient with low lip line due to vertical maxillary deficiency, and to follow metric, you could see the lateral oscillogram taken in the rest position, which is used to measure negative lip line at rest. The best reference for impacting or lengthening the maxilla is the incisor display at rest, taking upper lip length and any incisor attrition into account. The full smile does not make a good reference, partly because of the individual variation in lip mobility. A short upper lip should not be treated by shortening the maxilla unless the facial outline can accommodate such a change. It should also be noted that in maxillary impaction, the upper lip shortens by as much as 50% of the surgical skeletal intrusion. Crown height. The average vertical height of the maxillary central incisor is 10.6 millimeters in males and 9.8 millimeters in females. A short crown can be due to attrition or excessive gingival encroachment. If there is little or no incisor display at rest, but the lip line is normal and smiling, the crown height can be increased incisively with cosmetic dentistry. Gingivectomy or the crown lengthening procedure with crestal bone removal is recommended when short clinical crowns are associated with a gingival smile and a normal incisor display at rest. Here you could see a patient with a gingival smile, overbite, and short clinical crowns. Now the picture B is the same patient, but after orthodontic maxillary incisor intrusion and crown lengthening surgery. Vertical dental height. As mentioned earlier, the incisor exposure at rest rather than the overbite determines the vertical position of the incisal edge, all other factors being equal. Therefore, a deep bite should be corrected by maxillary incisor intrusion in a patient with excessive incisor display at rest. But with posterior extrusion and low incisor intrusion in a patient with a normal lip line at rest. The opposite applies to an open bite, which should be corrected by maxillary incisor extrusion if there is an inadequate incisor display at rest, but with posterior intrusion or low incisor extrusion if the lip line is normal at rest. Incisor inclination. Proclined maxillary incisors, whether in a Class 2 Division 1 malocclusion or in a Class 3 compensation, tend to reduce the incisor display at rest and in smiling. On the other hand, uprighted or retroclined maxillary incisors, as seen in Class II Division II malocclusion or after orthodontic retraction without torque control, tend to increase the incisor display. Maxillary incisor inclination can best be assessed on profile and Doppler smile photographs, which should become standard orthodontic records. Here you could see a flip line with reduced incisor display due to proclined maxillary incisors on the picture A, and in the photo B you could see a normal incisor display after orthodontic brightened or maxillary incisors. Smile arch. The smile arch is the relationship between a hypothetical curve drawn along the edges of the maxillary anterior teeth and the inner contour of the lower lip in the post-smile. The curvature of the incisal edge appears to be more pronounced for women than for men and tends to flatten with age. The curvature of the lower lip is usually more pronounced in younger smiles. In an optimal smile arch described as consonant, the curvature of the maxillary incisal edge coincides with or parallels the border of the lower lip in smiling. The lower lip can either touch, not touch, or slightly cover the upper lip incisal edges. In one study of untreated subjects, the patients whose lower lips touched or did not touch the incisal edge had a higher aesthetic score than those whose incisal edge was slightly covered. 15.76% of the sample. In a non-consonant smile arch, the maxillary incisal edges are either flat or reversed relative to the curvature of the lower lip. Smile arches were found to be flatter in orthodontically treated patients than in an untreated group, with normal occlusions resulting in a denture mouth appearance. In other studies, flattening of the smile arch was found in 1/3 of the 30 treated patients, but in only 2 of the 30 untreated subjects. Here you could see a patient with a flat smile arch after orthodontic treatment. Upper lip curvature. The upper lip curvature is assessed from the central position of the corner of the mouth in smiling. It is upward when the corner of the mouth is higher than the central position, straight when the corner of the mouth and the central position are at the same level, and downward when the corner of the mouth is lower than the central position. Upward and straight lip curvatures are considered more aesthetic than downward lip curvatures. In a non-orthodontic population with normal occlusions, upward lip curvatures were rare, but straight and downward lip curvatures were almost equally prevalent. Because it is a muscle driver position, upper lip curvature is not subject to alteration by orthodontic therapy. Downward lip curvature could therefore be considered a limiting factor in achieving an optimal smile. You could see the upper lip curvature on the picture A. It is an upward, and the picture B is straight, and the picture B is downward. Lateral negative space. The transverse dimension of the smile is also referred to as transverse dental projection. Lateral negative space is the buccal corridor between the posterior teeth and the corner of the mouth in smiling. Although the prosthodontic literature describes the smile like in buccal corridors as unrealistic looking, and denture-like orthodontics refer to buccal corridor as negative spaces to be eliminated by transverse maxillary expansion. A first molar to first molar smile is often advocated in orthodontics, but is considered evidence of a poorly constructed denture in prosthodontics. In studies measuring the number of teeth displayed in the smiles of young subjects with normal occlusions, those displaying the first molars were ranked the highest aesthetically. The picture A is the patient with lateral negative space, and the picture A is the same patient but after rapid palatal expansion or after rapid maxillary expansion. For smaller display was found in only 3.7% of the sample. However, with most of the subjects, 57% display in only the second premolars. In fact, non-extraction treatment with maxillary expansion does not necessarily improve the attractiveness of the smile. Research has shown that premolar extraction does not lead to arch constriction or a widening of buccal corridors. Furthermore, repeated surveys of lay persons have failed to establish any adverse aesthetic perception of negative spaces. Arch form also affects the transverse dimension of the smile. A broad arch is more likely to fill the buccal corridors than a narrow and constricted arch. In addition, buccal corridors are heavily influenced by the anteroposterior position of the maxilla relative to the lip drape. Moving the maxilla forward will reduce the negative space because a wider portion of the arch will come forward to fill the intercommissure space. In smiling, the width of the mouth increases by as much as 30%. Therefore, an excessive transverse lip extension in smiling would theoretically produce a wider buccal corridor. Smile symmetry. Smile symmetry is the relative positioning of the corners of the mouth in the vertical plane. Can be assessed by the parallelism of the commissure and pupillary lines. Although the commissures move up and laterally in smiling, studies have shown a difference in the amount and direction of movement between the right and left sides. A large differential elevation of the upper lip in an asymmetrical smile may be due to a deficiency of muscular tonus on one side of the face. Mere functional exercises have been recommended to help overcome this deficiency and restore smile symmetry. An oblique commissural line in an asymmetrical smile can give the illusion of a transverse cant of the maxilla or a skeletal asymmetry. On the left photo, you could see a patient with asymmetrical smile line due to a deficiency of muscle tonus on one side of face. Frontal occlusal plane. The frontal occlusal plane is represented by a line running from the tip of the right canine to the tip of the left canine. A transverse cant can be caused by differential eruption of the maxillary anterior teeth or skeletal asymmetry of the mandible. This relationship of the maxilla to the smile cannot be seen on intraoral images or study casts, and smile photographs can also be misleading. Therefore, clinical examination and digital video documentation are essential in making the differential diagnosis between smile asymmetry, a canted occlusal plane, and facial asymmetry. Having the patient bite on a tongue blade or a mouth mirror in the premolar area during the clinical examination is a good way to recognize an asymmetrical cant of the maxillary frontal occlusal plane. On the left picture, you can see a patient with canted occlusal frontal plane and unilateral posterior gingival smile. Dental components. The first 6 components of the smile consider the relationship between the teeth and lips, and the way the lips and soft tissue frame the smile. A pleasant smile also depends on the quality and beauty of the dental elements it contains and their harmonious integration. Dental components of the smile include the size, shape, color, alignment, and crown angulation or tip of the teeth, the midline, and arch symmetry. The dental midline is an important focal point in an aesthetic smile. A practical and reliable method of locating the facial midline, which normally coincides with the dental midline, is to use 2 anatomical landmarks, mesium and the base of the philtrum, known as the Cupid's bow in the center of the upper lip. A line drawn between these 2 landmarks not only locates the facial midline, but also determines its direction. The parallelism between the maxillary central incisor midline and the facial midline is more important than the coincidence between the dental and facial midlines. In fact, in one study, a 4 mm maxillary midline deviation was not detected by dentists or lay persons, whereas a 2 mm deviation in size angulation was rated as noticeably unattractive. A mild midline discrepancy is acceptable as long as the interproximal contact area, or connecting space, between the maxillary central incisors is vertical. Arch symmetry is also important in achieving a balanced smile, which is why cases with back-shaped or missing lateral incisors are particularly challenging. Other factors that can disturb the continuity of the dental composition include midline diastemas and lack of interproximal contacts. On the photo, you could see a patient with unattractive maxillary central incisor midline angulation, referred to as canted midline. A patient with arch asymmetry due to peg-shaped lateral incisor and missing lateral incisor. Symmetrical arch after extraction of peg lateral and orthodontic space closure. Gingival components. The gingival components of the smile are the color, contour, texture, and height of the gingiva. Inflammation, blunted papilla, open gingival embouchures, and uneven gingival margins detract from the aesthetic quality of the smile. The space created by a missing papilla above the central incisor contact point, referred to as a black triangle, may be caused by root divergence, triangular teeth, or advanced periodontal disease. Root paralleling and flattening of the mesial surfaces of the central incisors, followed by space closure, will lengthen this contact area and move apically toward the papilla. The gingival margins of the central incisors are normally at the same level of slightly lowered than those of the canines, while the gingival margins of the lateral incisors are lower than those of the central incisors. Gingival margin discrepancies may be caused by attraction of the incisal edge, ankylosis due to trauma in a growing patient, overcrowding, or delayed migration of the gingival tissue. The gingival margins can be leveled by orthodontic intrusion or extrusion, or by periodontal surgery, depending on the lip line, the crown heights, and the gingival levels of the adjacent teeth. Examination. In an examination, the clinician uses sight, touch, and hearing to detect abnormal conditions. To avoid mistakes, it is critical to record what is actually observed rather than to make diagnostic comments about the condition. For example, swelling, redness, and bleeding on probing of gingival tissue should be recorded, rather than gingival inflammation, which implies a diagnosis. Thorough examination and data collection are needed for prospective patients who desire fixed prosthodontic treatment, and more detailed protocols for this effort can be obtained from various textbooks of oral diagnosis. The patient's general appearance, gait, and weight are assessed. Skin color is noted, and vital signs such as respiration, pulse, temperature, and blood pressure are measured and recorded. Middle-aged and older patients can be at higher risk for cardiovascular disease. Relatively inexpensive cardiac monitoring units are available for in-office use. Patients whose vital sign measurements are outside normal range should be referred for a comprehensive medical evaluation before definitely prosthodontic treatment is initiated. Here you can see a cardiac monitor printout and representative ECG findings. Extraoral examination. Special attention is given to facial asymmetry because small deviations from normal may hint at serious underlying conditions. Cervical lymph nodes are palpated, as are the TMGs and the muscles of mastication. Temporomandibular joint. The clinician locates the TMGs by palpating bilaterally just anterior to the auricular trachea while the patient opens and closes the mouth. So the clinician locates the TMGs by palpating bilaterally just anterior to the auricular trachea while the patient opens and closes the mouth. This enables a comparison between the relative timing of left and right condylar movements during the opening stroke. Asynchronous movement may indicate a disc displacement that prevents one of the condyles from making a normal translatory movement. Auricular palpation with light anterior pressure helps identify potential disorders in the posterior attachment of the disc. Tenderness or pain on movement is noted and can be indicative of inflammatory changes in the retrodiscal tissues, which are highly vascular and innervated. Clicking in the TMG is often noticeable through auricular palpation, but may be difficult to detect in palpation directly over the lateral pole of the condylar process because the overlying tissues can muffle the click. By placing the fingertips on the angles of the patient's mandible, the clinician can identify even a minimal click because very little soft tissue lies between the fingertips and the mandibular bone. Here you could see the auricular palpation of the posterior aspects of the temporomandibular joints. A maximum mandibular opening resulting in less than 35 millimeters of interincisal movement is considered restricted, because the average opening is greater than 50 millimeters. Such restricted movement and opening can be indicative of intercapsular changes in the joints. Similarly, any midline deviation on opening or closing is recorded. The maximum lateral movements of the patient can be measured. Normal is approximately 12 millimeters. Maximum opening of more than 50 millimeters on the picture A and lateral movement of approximately 20 millimeters on the picture B, they are normal. Muscles of mastication. The masseter and temporal muscles, as well as other relevant postural muscles, are palpated for signs of tenderness. Palpation is best accomplished bilaterally and simultaneously. This allows the patient to compare and report any differences between the left and right sides. Light pressure should be used. The amount of pressure one can tolerate when gently pushing on one's closed eyelid without feeling discomfort is a good comparative measure. And if any difference is reported between the left and right sides, the patient is asked to classify the discomfort as mild, moderate, or severe. If there is evidence of significant asynchronous movement of GMG dysfunction, a systematic sequence for comprehensive muscle palpation should be followed as described by Solder and Kroll-Paulson and Olson. Each palpation site is given a numerical score based on the patient's response. If neuromuscular or TMG treatment is initiated, the examiner can then repalpate the same sites periodically to assess the response to treatment. Here you can see the muscle palpation, the masseter, picture A, the temporal muscle, the picture B, the trapezius muscle, the picture D, and the sternocleidomastoid muscle, and the floor of the mouth on the picture E. The patient size for assessing muscle tenderness. Temporomandibular joint capsule, the lateral and dorsal. Masseter, deep and superficial, temporal muscle, anterior and posterior. D is the vertex. Neck, nape, and base. Sternocleidomastoid muscle, insertion, body, and origin. Medial pterygoid muscle in the picture G. Posterior digastric muscle H. Temporal tangent E. Lateral pterygoid muscle G. Palpation is the best done bilaterally, simultaneously asking the patient to identify any differences between left and right side. Lips. Patient is observed for tooth visibility during normal and exaggerated smiling. This can be crucial in fixed prosthodontic treatment planning, especially for margin placement of certain metal ceramic crowns. Some patients show only the maxillary teeth during smiling. More than 25% do not show the gingival third of the maxillary central incisors during an exaggerated smile. The extent of the smile depends on the length and mobility of the upper lip and the length of the alveolar process. When the patient laughs, the jaw opens slightly and a dark space is often visible between the maxillary and mandibular teeth. This has been called the negative space. Missing teeth, diastemas, and fractured or poorly restored teeth disrupt the harmony of the negative space and often require correction. The figure 114, you see the negative space between the maxillary and mandibular teeth is assessed during the examination. Intraoral examination. The intraoral examination can reveal considerable information concerning the condition of the soft tissues, teeth, and supporting structures. The tongue, floor of the mouth, vestibule, cheeks, and heart, and soft palates are examined, and any abnormalities are noted. This information can be evaluated properly during treatment planning only if objective and indecisive rather than vague assessments are used. Periodontal examination. A periodontal examination should provide information regarding the status of bacterial accumulation, the response of the host tissues, and the degree of reversible and irreversible damage. Because long-term periodontal health is essential for successful fixed prosthodontics, existing periodontal disease must be corrected before any definitive prosthodontic treatment is undertaken. Gingiva. The gingiva should be lightly dried before examination, so that moisture does not obscure subtle changes or detail. Color, texture, size, contact, consistency, and position are noted and recorded. The gingiva is then carefully palpated to express any exudate or pus that may be present in the sulcal area. Healthy gingiva is pinked, stable, and firmly bound to the underlying connective tissues. The free margin of the gingiva is knife-edged and sharply pointed. Papilla fill the interproximal spaces. Any deviation from these findings should be noted. With the development of chronic marginal gingivitis, the gingiva becomes enlarged and bulbous. Loss of stippling occur, the margin and papilla are blunted, and bleeding and exudate are observed. The width of the band of attached keratinized gingiva around each tooth may be assessed by measuring the surface band of keratinized tissue in an epicoronal dimension with a periodontal probe and subtracting the measurement of the sulcus depth. Another method of obtaining this measurement by visual examination is to gently depress the marginal gingiva with the side of a periodontal probe or explorer. At the mucogingival (MGG), the effect of the instrument is seen to end abruptly, indicating the transition from tightly bound gingiva to more flexible mucosa. Injection anesthetic solution into the non-keratinized mucosa close to the MGG to make the mucosa balloon slightly is the third method of visualizing the MGG. However, this is done only if the other methods do not provide the desired information. What about periodontium? The periodontal probe is one of the most reliable and useful diagnostic tools available for examining the periodontium. It provides a measurement in millimeters of the depth of frontal pockets and healthy gingival sulci on all surfaces of each tooth. In this examination, the probe is inserted essentially parallel to the tooth and is worked circumferentially through the sulcus in firm but gentle steps. The examiner determines the measurement when the probe is in contact with the apical portion of the sulcus. You can see the three types of sulcus pocket measuring probes. Correct position of a periodontal probe in the interproximal sulcular area parallel to the root surface and in vertical directions as far interproximal as possible, C and D. Gradiated truncation probe on the picture D. Thus, any sudden change in the attachment level can be detected. The probe may also be angled slightly from 5 to 10 degrees in the interproximal areas to reveal the topography of an existing lesion. Probing depths, usually 6 per tooth, are recorded on a periodontal chart which also contains other data pertinent to the periodontal examination. Tooth mobility or malposition. Open or deficient contact areas, inconsistent marginal ridge height, missing or impacted teeth, areas of inadequate attached keratinized gingiva, gingival recession, percussion involvements, and malpositioned frenum attachments. Clinical attachment level. Documenting the level of attachment helps the clinician to determine the amount of periodontal destruction that has occurred and is essential in rendering a diagnosis of periodontitis. Example, loss of connective tissue attachment. This measurement also provides the clinician with more detailed and accurate information regarding the prognosis of an individual tooth. The clinician attachment level is determined by measuring the distance between the apical extent of the probing depth and a fixed reference point on the tooth. Most commonly either the apical extent of restoration and or the cemento-enamel junction. This measurement can be documented on modified periodontal charts and incorporated with the standard periodontal documentation to complete the clinical periodontal examination. When the frame margin of the gingiva is located on the clinical crown and the level of the epithelial attachment is at the CAG, there is not loss of attachment, and recession is noted as a negative number. When the level of the epithelial attachment is on the root structure and the free margin of the gingiva is at the CAG, attachment loss equals the probing depth and the recession is 0. Here you can see a chart. You can see a chart for recording pocket depth. The parallel lines are approximately 2 millimeters apart. The notations involved in using the chart are as follows. Block out any missing teeth, draw a red X through the crown of any tooth that is to be extracted, record the gingival level with a continuous blue line, record pocket depth with a red line interrupted at the proximal surfaces of each tooth, shade the pocket formed on each tooth with a red pencil between the red and blue lines, indicate bifurcation or trifurcation involvements with a small red X at the involved areas. Record open contacts with vertical parallel lines through the area. On the A, record improper contacts with a wavy red line through the area. Record gingival with a red spur through the area. Outline cavities and faulty restorations of periodontal significance in red indicate rotated teeth by outlining in blue to show their actual position. Here you can see this charting of conditions before periodontal treatment. There are different surfaces such as occlusal, lingual, facial, and the side, right side and left side, the teeth on the maxillary and on the mandibular. In a situation in which there is increased periodontal destruction and recession, the loss of attachment measurement equals the probing depth plus the measurement of recession. Clinical attachment loss is a measure of periodontal destruction at a site rather than current disease activity, and it may be considered the diagnostic gold standard for periodontitis. It should be documented in the initial periodontal examination. It is an important consideration in the development of the overall diagnosis, treatment plan, and prognosis of the dentition and can be an effective research tool. Dental charting. An accurate charting of the stage of the dentition reveals important information about the condition of the teeth and facilitates treatment planning. Adequate charting, in addition to all periodontal information, must show the presence or absence of teeth. Dental caries, restorations, wear, faceting, and abrasions. Fractures, malformations, and erosions. Missing teeth often have an effect on the position of adjacent teeth. Similarly, the presence of dental caries on the interproximal surface should alert the examiner to carefully inspect the adjacent proximal wall, even if caries is not apparent radiographically. The degrees and extent of caries development over time can have a considerable effect on the eventual outcome of fixed prosthodontic treatment. Here you can see an appropriate charting system designs the location, type, and extent of existing restorations and the presence of any disease condition, all of which become part of the permanent parent record. You can see radiographic findings obtained from the full mouth series are correlated with the clinical findings and noted in the record. C/E. Charting is performed to provide a quick reference to conditions in the mouth. The following may be useful. Amalgam restorations are depicted by an outline drawing blocked in solidly to show the size, shape, and location of the restoration. Tooth-colored restorations, D. Tooth-colored restoration are depicted by an outline drawing of the size, shape, and location of the restorations. Gold restorations are depicted by an outline drawing inscribed with diagonal lines to show the size, shape, and location of the restoration. Picture 4. Missing teeth are denoted by a large X on the facial, lingual, and occlusal diagrams of each tooth that is not visible clinically or on radiographs. The condition and type of the existing restorations are noted: amalgam cast, gold, composite, resin, and all ceramic. Open contacts and areas where food impaction occurs must also be identified. The presence of wear faced is indicated of sliding contact sustained over time and thus may indicate parafunctional activity. where facets are often easier to see on diagnostic tests. However, during the clinical examination, the location of any observed facet is recorded. Fracture line Fracture lines in teeth may necessitate fixed prosthodontic intervention, although minor hairline cracks in walls that are not subject to excessive loading can often go untreated and simply be observed at recall appointments. The location of fractures should be indicated on the chart, as should any other abnormalities. Occlusal examination. The initial clinical examination starts with the clinicians asking the patient to make a few simple opening and closing movements while the clinician carefully observes the opening and closing strokes. The objective is to determine to what extent the parent's occlusion differs from the ideal and how well the patient has adapted to this difference. Special attention is given to initial contact, tooth alignment, eccentric context, and jaw maneuverability. Initial tooth contact. The relationship of teeth in both centric relation and the maximum interspacing should be assessed. If all teeth come together simultaneously at the end of terminal hinge closure, the centric relationship (OCR) position of the patient is said to coincide with the maximum intercuspation. The patient is guided into terminal hinge closure to detect where initial tooth contact occurs. The clinician should ask the patient to close feathered light until any of the teeth touch and to have patient help identify where that initial contact occurs by asking him or her to point at the location. If initial contact occurs between two posterior teeth, usually molars, the subsequent movement from the initial contact to the ME position is carefully observed and its direction noted. This is referred to as a slide from CR to MI. The presence, direction, and estimated magnitude of the slide are recorded, and the teeth on which initial contact occurs are identified. Any such discrepancy between CR and MI should be evaluated in the context of other signs and symptoms that may be present. Elevated muscle tone previously observed during the extraoral examination, mobility on the teeth where initial contact occurs, were faced on the teeth involved in the slide. General alignment. The teeth are evaluated for crowding, rotation, supraeruption, spacing, malocclusion, and vertical and horizontal overlap. Teeth adjacent to edentulous spaces often have shifted position slightly. Small amounts of tooth movement can significantly affect fixed prosthodontic treatment. Tip teeth affect tooth preparation design, or in several cases may result in the need for minor tooth movement before restorative treatment. Supraerupted teeth are often overlooked clinically but frequently complicate fixed dental prosthesis design and fabrication. The relative relationship of adjacent teeth to teeth that require fixed prosthodontic treatment is important. A tooth may have drifted into the space previously occupied by the tooth in need of treatment because a large filling was previously lost. Such changes in alignment can seriously complicate or preclude fabrication of a cast restoration for the damaged tooth and may even necessitate its extraction. On this photograph, you could see alignment of the dentition can be assessed intraorally, although diagnostic tests allow a more detailed assessment. This patient has careless-free teeth in good alignment. Lateral and protrusive context. The degree of vertical and horizontal overlap of the teeth is noted. When asked, most patients are capable of making an unguided protrusive movement. During this movement, the degree of posterior disclusion that results from the overlaps of the anterior teeth is observed. The patient is then guided into lateral extrusive movements and the presence or absence of context on the non-working side, and then the working side is noted. Such tooth contact in eccentric movements can be verified with a thin mylar strip, a shim stalk. Any posterior casts that hold the shim stalk are evident. Teeth that are subject to excessive loading may develop varying degrees of mobility. Tooth movement fremitus should be identified by palpation. If a heavy contact is suspected, a finger placed against the buccal or labial surface while the patient lightly taps the teeth together helps locate fremitus in ME. Jaw maneuverability. The ease with which the patient moves the jaw and the way it can be guided through hinge closure and excursive movements should be assessed, because these factors are a good guide to neuromuscular and masticatory function. If the patient has developed a pattern of protective reflexes, manipulating the jaw is difficult. The patient's restricted maneuverability is recorded. Radiographic examination. Radiographs provide essential information to supplement the clinical examination. Detailed knowledge of the extent of bone support and the root structure of each standing tooth is essential for establishing a comprehensive fixed prosthodontic treatment plan. Although radiation exposure guidelines recommend limiting the number of radiographs to only those that will result in potential changes in treatment decisions. A full periapical series is normally required for new patients so that a comprehensive fixed prosthodontic treatment plan can be developed. Patient exposure can be minimized by using a technique that provides the most information with a minimal need to repeat films and by using appropriate protection. The use of digital radiography can further help reduce radiation exposure. Panoramic films provide useful information about the presence or absence of teeth. They are especially helpful in assessing third molars and infections, evaluating the bone before implant placement, and screening edentulous arches for bordered root tips. However, they do not provide a sufficiently detailed view for assessing bone support, root structure, caries, or periapical disease. Special radiographs may be needed for the assessment of TMG disorders and a wide variety of pathologies ranging from bone and mineral disorders to metabolic disorders, genetic abnormalities, and soft tissue calcifications, such as carotid artery calcification. For assessment of the TMGs, a transcranial exposure with the help of a positioning device reveals the lateral third of the mandibular condyle and can be used to detect structural and positional changes. Vitality testing. Before any restorative treatment, pulpal health must be assessed, usually by measuring the response to gentle tapping with an instrument or percussion, and thermal or electrical stimulation. A diagnosis of non-vitality can be confirmed by preparing a test cavity without the administration of local anesthetic. Vitality tests, however, assesses only the afferent nerve supply. Misdiagnosis can occur if the nerve supply is damaged but the blood supply is intact. Careful inspection of radiographs is therefore essential in the examination of such teeth. Diagnosis and prognosis. Not all patients seeking fixed prosthodontic treatment have diagnostic problems. Nevertheless, diagnostic errors are possible, especially when a patient complains of pain or symptoms or of occlusal dysfunction. Treatment may be needed to eliminate obvious dental caries, to restore a fractured prosthesis, or to replace a missing tooth. A logical and systematic approach to diagnosis helps avoid mistakes. Differential diagnosis. When the history and examination are completed, a differential diagnosis is made. The practitioner should determine the most likely causes of the observed condition or conditions and record them in order of probability. A definitive diagnosis can usually be developed after such supporting evidence has been assembled. A typical diagnosis condenses the information obtained during the clinical history taken and examination. For instance, a diagnosis could read as follows: 20-year-old male, no significant medical history, vital signs normal, chief complaint: mesolingual cast fracture on tooth number 30, teeth number 1 and number 16, 17, 18, and 32 are missing. Patient reports significant post-operative discomfort after previous molar extraction. High smile line, caries number 6 mesial, number 12 distal, number 20 mesio-occlusal, and number 30 mesio-occlusal distal. This hypothetical scenario summarizes the patient's problems, allowing the subsequent prioritization as a treatment plan is developed. In this case, the patient's chief complaint likely has a longer-term history that has only recently led to symptoms that the patient could identify, causing him to seek care. Prognosis. The prognosis is an estimation of the likely course of a disease. It can be difficult to make, but its importance to patient prevention and successful treatment planning must nevertheless be recognized. The prognosis of dental disorders influenced by general factors, for example, age of the patient, lowered resistance of oral environment, and local factors. They are the portion supply to a given tooth, access for oral hygiene measures. A young person with periodontal disease has a more guarded prognosis than does an older person with the same disease experience. In the younger person, their disease has followed a more virulent course because of the generally less developed systemic resistance. This fact should be reflected in treatment planning. Fixed prostheses function in a hostile environment. The moist oral environment is subject to constant changes in temperature and acidity and considerable load fluctuation. A comprehensive clinical examination helps identify likely prognosis. All facts and observations are first considered individually and then correlated appropriately. General factors. The overall caries rate of the parent's dentition indicates future risk to the patient if the condition is left untreated. Important variables can include the patient's understanding and comprehension of plaque control measures, as well as the physical ability to perform those tasks. Systemic problems analyzed in the context of the patient's age and overall health provide important information. Diabetic patients are prone to a high incidence of periodontal disease, and special precautionary measures may be indicated before treatment begins. Such conditions also affect the overall prognosis. Some patients are capable for an extremely high occlusal force, whereas others are not. If an elevated muscle tone or hypertrophied elevator muscle is identified during the extraoral examination and multiple intraoral wear facets are observed, loading of the teeth is considerably higher than in the dentition of a frail 90-year-old who tries easily when asked to close. Other important factors in determining overall prognosis are the history and success of previous dental treatments. If a patient's previous dental care has been successful over a period of many years, a better prognosis can be anticipated than when apparently properly fabricated prostheses fail or become dislodged within a few years of initial placement. Local factors. The observed vertical overlap of the anterior teeth has a direct effect on the load distribution in the dentition, and thus can have an effect of the prognosis. In the presence of favorable loading, minor tooth mobility is less a concern than in presence of unfavorable directed or high load. Impactions adjacent to a molar that will be crowned may pose a serious threat to younger individual, in whom additional growth can be anticipated, but it may be of lesser concern in an older individual. Individual tooth mobility, root angulation, root structure, crown root ratios, and many other variables all have an effect on the overall fixed prosthodontic prognosis. They are addressed later in this presentation. Prosthodontic Diagnostic Index, or PDI, for the partially edentulous and the completely dentate patient. These guidelines are intended to help practitioners determine appropriate treatments for their patients. For each index, 4 categories, Class 1 to Class 4, are defined. Class 1 represents an uncomplicated clinical situation, and Class 4 represents a complex clinical situation. The indices are designed for use by dental professionals involved in the diagnosis and treatment of partially edentulous and completely dentate patients. Potential benefits of the system include improved intraoperator consistency, improved professional communication, insurance reimbursement of measure with complexity of care, improved screening tool for dental school admission clinics, and standardized criteria for outcomes assessment and research. Enhanced diagnostic consistency and simplified aid in the decision to refer the patient. Each class is differentiated by specific diagnostic criteria. Ideal or minimal, moderately compromised, substantially compromised, or severely compromised of the following: location and extent of the dental area or areas, condition of the abutment teeth, occlusal scheme, and residual ridge. For the completely dentate patient, only tooth condition and occlusal scheme are evaluated. Location and extent of the edentulous areas. In the ideal or minimally compromised edentulous area, the edentulous span is confined to a single arch and one of the following: an anterior maxillary span that does not exceed 2 missing incisors, an anterior mandibular span that does not exceed 4 missing incisors, and a posterior maxillary mandibular span that does not exceed 2 premolars or 1 premolar and 1 molar. In the moderately compromised edentulous area, the edentulous span is in both arch, and one of the following conditions exists. The span includes any anterior maxillary span that does not exceed 2 missing incisors. The span includes any anterior mandibular span that does not exceed 4 missing incisors. The span includes any posterior maxillary mandibular span that does not exceed 2 premolars or 1 premolar and 1 molar, and the maxillary mandibular canine is missing. The substantially compromised edentulous area includes any posterior maxillary or mandibular span that is greater than the 3 missing teeth or 2 molars. Any edentulous span, including anterior and posterior areas of 3 or more missing teeth. And the severely compromised edentulous area includes any edentulous area or a combination of edentulous area whose care requires a high level of patient compliance. Condition of the abutment teeth. Ideal or minimally compromised abutment teeth condition. No pre-prosthetic therapy is indicated. If moderately compromised abutment teeth condition. Tooth structure is insufficient to retain or support intracoronal restorations in 1 or 2 sextants. Abutments require localized adjunctive therapy, periodontal, endodontic, or orthodontic procedures in 1 or 2 extents. Substantially compromised abutment teeth condition. Tooth structure is insufficient to retain or support intracoronal or extracoronal restorations in 4 or more sextants. Abutments require extensive adjunctive therapy, periodontal, endodontic, or orthodontic procedures in 4 or more 6 and severely compromised abutment teeth condition. Abutments have a guarded prognosis. Occlusal scheme. In all minimally compromised occlusal scheme, no prosthetic therapy required. Class 1 molar and jaw relationships. Moderately compromised occlusal scheme. Occlusal scheme requires localized adjunctive therapy, enameloplasty or premature occlusal contacts. Class 1 molar and jaw relationships. Substantially compromised occlusal scheme. Entire occlusal scheme requires re-establishment, but without any change in the occlusal vertical dimension. Class 2 molar and jaw relationship. Severely compromised occlusal scheme. Entire occlusal scheme requires re-establishment with changes in the occlusal vertical dimension. Class 2 division 2 and Class 3 molar and jaw relationships. Residual ridge. The criteria published for the classification system for complete edentulism are used to categorize any edentulous span present in the partially edentulous patient. Classification system. The four criteria in their sub-classifications are organized into an overall classification system for partial edentulism. The two criteria provide the system for completely edentulous patients. Class 1. This class is characterized by ideal minimal compromise in the location and extent of edentulous area, abutment conditions, occlusal characteristics, and residual ridge conditions. All four of the diagnostic criteria are favorable. The location and extent of the edentulous area are ideal or minimally compromised. The edentulous area is confined to a single arch. The edentulous area may include an anterior maxillary span that does not exceed 2 incisors, any anterior mandibular span that does not exceed 4 mesial incisors, or any posterior span that does not exceed 2 premolars or 1 premolar and 1 molar. The abutment condition is that are minimally compromised with no need for prosthetic therapy. The occlusion is ideal or minimally compromised with no need for prosthetic therapy. Maxillomandibular relationship consists of class 1 molar and jaw relationships. Residual ridge morphology conforms for the class 1 complete edentulism description. So here you could see class 1 patient. This patient is characterized as class 1 because of an ideal or minimally compromised edentulous area, abutment condition, and occlusion. There is a single edentulous area in 1/6. The residual ridge is considered type A. Here you can see a class 1 patient. The patient is categorized as class 1 because an ideal or minimally compromising tooth condition and occlusal scheme is exhibited. Class 2. This class is characterized by moderately compromised location and extent of edentulous areas in both arches, abutment conditions necessitating localized adjunctive therapy, occlusal characteristics necessitating localized adjunctive therapy, and residual ridge conditions. The location and extent of the edentulous area are moderately compromised. Edentulous areas may exist in one or both arches. The edentulous area do not compromise the physiologic support of the abutments. Edentulous areas may include any anterior maxillary span that does not exceed 2 incisors, and anterior mandibular span that does not exceed 4 incisors, any posterior span, maxillomandibular, that does not exceed 2 premolars or 1 premolar, and 1 molar of any mesenchine, maxillary or mandibular. Second, condition of the abutments moderately compromised. Abutments is 1 or 2/6 have insufficient tooth structure to retain or support intracorneal or extracorneal restoration. Occlusion is moderately compromised. Occlusal correction requires localized adjunctive therapy. Maxillomandibular relationship is class 1 molar and jaw relationships. Residual ridge structure conforms for the class 2 complete edentulism description. You can see the class 2 patient. This patient is categorized as class 2 because he has edentulous areas in 2/6 in different arches. You can see a class 2 patient.